Hello everyone. This lecture was held in May 2023 during the 20th LASRA Peru Congress. The topic I have been assigned to develop is anatomic barriers to paraspinal blocks. During the following minutes, we will perform a thorough review of the anatomical elements of the posterior thoracic wall and which ones may limit or, on the contrary, allow the passage of local anesthetic in paraspinal blocks. Paraspinal blocks are a group of regional techniques described in the last decade whose objective is to obtain a block of the spinal ventral branches in a simple, fast, and safe manner. They are a group of procedures that consist of the injection of high volumes of local anesthetic into muscle planes of the posterior wall of the chest. In 2016, MAURICIO FORERO opened Pandora's box by describing the ESP block. This block, as you all know, consists of the injection of local anesthetic between the transverse processes and the erector spinae muscle. But if we review the literature carefully, and without any intention of taking away the credit from Dr. FORERO, the first paraspinal block, the retrolaminar block, was described as early as 2006. In a case report written in German, Dr. Pfeiffer described the paraspinal diffusion of local anesthetic when injected over the thoracic vertebral laminae. I could not find any actual picture of Dr. Pfeiffer online, but Michel seems an alternative he would approve. Later, Christopher Voskopoulos described it with ultrasound guidance in 2013. Definitely less pretty than Pfeiffer's. While MAURICIO proposes injecting above the transverse processes to perform the ESP block, Pfeiffer describes the retrolaminar approach, above the vertebral laminae. Both the ESP block and the retrolaminar block are the starting gun for paraspinal blocks of the thoracic wall. Regardless of where we deposit the local anesthetic, the truly interesting and controversial aspect of these regional techniques is the degree of spread of the local anesthetic to the paravertebral space. It is not surprising that paraspinal blocks are also referred to as paravertebral-like blocks. Although, as we have already seen, and sticking to reality, paraspinal or paravertebral-like blocks were first described in 2006. It was not until MAURICIO described the ESP block when the great revolution of paraspinal blocks really occurred. So much so that in subsequent years variations in paraspinal blocks have been described with very different names, although many of them with the same meaning, trying to define the ideal place for the injection of local anesthetic. In this necessary standardization work of fascial blocks, the studies carried out in fascial blocks are collected, with a special section for paraspinal blocks. Given the relevance, number of studies, and evidence, paraspinal blocks are reduced to the ESP block, retrolaminar block, and the intertransverse block, ITP blocks. That includes a large number of possibilities with few variations among them. From here onward, we will analyze the barriers that we can encounter in the ESP block and intertransverse blocks. We will not mention the retrolaminar block, although its mechanism of action should be similar to what I will show you below. The topic we're going to address next has a high content of anatomy, so it may be long and tedious. To make it more didactic, I will try to graphically analyze the posterior thoracic wall, deconstructing it and rebuilding it repeatedly. We will start by talking about the vertebra, ribs, and ligaments. The thoracic vertebrae are formed by a prominent triangular spinous process with a characteristic oblique direction towards the caudal direction. Two pedicles, two laminae that overlap with the superior and inferior ones like the tiles of a roof, two transverse processes, and four articular processes, two superior and two inferiors. The articular pillar projects upward and downward from the laminae of each vertebra to the adjacent vertebra, with the inferior articular process being larger in size. The facet joint has an oblique orientation in the axial plane, making it difficult to identify ultrasonographically from a posterior approach. In addition to the complexity of the thoracic vertebra, we must add the presence of an additional bony structure, the ribs. The ribs are the bony framework that protects the thoracic cage and at the same time provide elasticity to allow breathing. The ribs articulate with the thoracic vertebrae through two joints, although in some of them there will be three, the costotransverse and costovertebral joints. The ligaments that provide stability to both joints are the costovertebral radiated ligament and the costotransverse radiated ligament, which we will call radiated costotransverse to avoid confusion with the rest, and the lateral costotransverse ligament. Between both joints we will find what is called the costotransverse space, a space delimited by the transverse process and rib without interposed ligamentous structures. The intertransverse ligaments are fibrous bands that connect the transverse processes of two adjacent vertebrae. Their function is to provide stability to the spinal column and limit excessive lateral movement between the vertebrae. On the other hand, the superior costotransverse ligaments are powerful ligaments that extend from the transverse processes of the superior vertebrae to the rib immediately below. These ligaments have an important function in stabilizing the costovertebral joints. This famous superior costotransverse ligament that everyone has heard of has been classically described as a continuity of the internal intercostal membrane, an aponeurotic termination of the internal intercostal muscle. In this three-dimensional video, you can observe the most relevant ligaments that could act as a barrier to the passage of local anesthetic when performing paraspinal blocks. Specifically, the superior costotransverse ligament, which marks one of the boundaries of the paravertebral space, has been postulated as the mandatory stop for the local anesthetic when injected from above. Its insertions include the superior transverse process, inferior rib, and continuity on its lateral side with the internal intercostal membrane. However, it does not have a medial insertion, leaving an open space for the passage of vasculonervous structures from the paravertebral space to the surface. The driving vehicle of any fascial block is the muscle and its fascia, making this anatomical structure deserving of special attention in this topic. Fascia is a connective tissue found throughout the body, forming a three-dimensional network that envelops and connects all tissues, organs, and bodily structures. The epimysial fascia is a layer of dense connective tissue that individually envelops and separates the muscles. In addition to separating muscle groups, the epimysial fascia helps maintain the integrity of each muscle and aids in transmitting forces between muscles and adjacent structures, such as tendons and bones. The aponeurotic fascia, also known as aponeurosis, is a layer of dense fibrous connective tissue that extends in the form of a flat sheet or band and is found in areas where a strong and resistant connection between muscles and bones is needed. This aponeurotic fascia has special importance in certain areas of the body, such as the lumbar level. The thoracolumbar fascia could constitute a barrier, or on the other hand, a diffusion belt that would justify the mechanism of action of some of the fascial blocks of the abdominal wall. In the posterior thoracic wall, if we perform a virtual dissection, starting from the deepest part of this paraspinal space, we will find a group of muscular filaments and ligamentous structures that has classically been called the intertransverse connective tissue complex. Multifidus, intertransverse, interspinous, rotator, longus, and brevis, costal levator muscles, and the ligaments that we have already seen confer stability to the vertebral costal junction. Dr. Escolar, a Spanish anatomist who also happened to be my grandfather, used to say that this musculature combed itself, referring to its filamentous appearance. So this complex leaves small porous spaces without forming a compact muscular group. On the surface we will find the erector spini muscle consisting of the spinalis longissimus and iliocostalis muscles. Although the muscle as a whole runs along the entire spine from the occiput to the sacrum, a part of it, the spinalis muscle, ends in the lower thoracic region. Two muscles that anesthesiologists do not take into account when we talk about the posterior thoracolumbar wall are the superior and inferior serratus posterior muscles. This is most likely because our planes of exploration are carried out at points where this muscle is not present. However, a very important aponeurotic fascia extends between them from an anatomical point of view, the thoracolumbar fascia. This would be for many anatomists the anatomical continuity of the thoracolumbar fascia at the thoracic level. The fourth layer, superficially, would be formed by the muscles rhomboid minor and major, which extend to the posterior border of the scapula. The most superficial muscular plane would be formed by the trapezius muscle and the second aponeurotic fascia that we will find in the posterior thoracic wall, the deep fascia. Thus, in the posterior thoracic wall, we will only find two aponeurotic fascia, the thoracolumbar fascia and the deep fascia. The rest are epimysial fascia that surround each muscle independently. If you notice, both are found in superficial planes to the erector spinae muscle, and therefore they do not seem to constitute an obstacle or barrier to the passage of the local anesthetic. On the other hand, it does not seem to constitute a diffusion belt that facilitates the spread of the local anesthetic and justifies in some way its mechanism of action. Once the anatomical structures that we will find in the thoracic paraspinal region have been described, it is crucial to describe our target, the paravertebral space. The thoracic paravertebral space is a wedge-shaped space located on both sides of the vertebral column. The parietal pleura forms the anterolateral boundary. The base is formed by the vertebral body, the intervertebral disc, and the intervertebral foramen with its contents. The transverse process and the superior costotransverse ligament form the posterior boundary. The thoracic paravertebral space contains adipose tissue in which the spinal nerve, intercostal vessels, and communicating and anterior rami, as well as the sympathetic chain anteriorly, are located. The spinal nerves are segmented into small bundles and lie freely in the adipose tissue of the paravertebral space. It communicates with the epidural space medially and with the intercostal space laterally. They also communicate with each other through the epidural and prevertebral spaces. The cranial extension of this paravertebral space is difficult to define and can vary. If we deconstruct the paravertebral space, starting from the posterior part most superficial, the external intercostal muscle extends medially, reaching almost to the vertebral bodies. The internal intercostal muscle merges into an aponeurotic membrane that we know as the internal intercostal membrane, which in turn will fuse or not, as we will see later, with the posterior costotransverse ligament, forming the posterior boundary or roof of the paravertebral space. The innermost intercostal muscle extends several centimeters before reaching the midline. The contents, formed by intercostal vessels and nerves, ramus communicans, and the sympathetic chain, extend below the costotransverse ligament, internal intercostal membrane, and internal intercostal muscle, passing over the innermost intercostal muscle. I have omitted the endothoracic fascia, which is formed by loose connective tissue, but it is not very clinically relevant for our procedures. All these structures are internally covered by the pleura, forming the floor of the paravertebral space. Once the anatomy of the posterior thoracic wall has been analyzed, we will analyze which of them could constitute a barrier for the local anesthetic in its route to the paraspinal space. In short, we will talk about the mechanism of action of paraspinal blocks, since all these anatomical structures could be an obstacle or a diffusion vehicle for the injected liquid. ESP block, independently of its defenders or detractors, has generated as many publications in just 7 years as the most popular fascial blocks have in over 20 years. However, its mechanism of action has been the main drawback of the paraspinal block since its inception. The lack of evidence on how the local anesthetic reaches the paravertebral space has been the reason why many of its detractors have tried to bury it soon after its birth. Anatomical studies that have tried to demonstrate the spread of the local anesthetic are still controversial to this day. Some have not found contrast or methylene blue in the spinal space, while others have, and even some studies describe reaching the epidural space. In this paper, Professor Kiji Chin explains the limitations of anatomical studies as well as radiological studies in demonstrating the mechanism of action of ESP block. Anatomical studies conducted with methylene blue tend to overestimate spread, while those using other substances such as silicones do the opposite. In addition, studies on cadavers do not take into account the mechanical effect and pressure of the paraspinal musculature and respiration in drug spread. Radiological studies, on the other hand, would be ideal, but sometimes can lead us to erroneous conclusions due to contrast absorption by the lymphatic system. This paper describes the possible mechanisms of action despite the lack of evidence. Special mention deserves the article by Dr. Schwartzman, my favorite Uruguayan, who conducted a study using nuclear magnetic resonance and its clinical correlation to describe the mechanism of action of the ESP block and the possible factors that may condition the spread of the local anesthetic. More anatomical or radiological articles with their clinical correlation would help us to better understand the mechanism of action of these blocks. Our anatomical knowledge at the time of the birth of these blocks in 2016 made it difficult to understand how such a consistent anatomical barrier, like the internal intercostal membrane, merged medially with a powerful and thick ligament, the superior costotransverse ligament, would not constitute a barrier to the passage of local anesthetic when injected at any point on its surface, whether in the plane of the erector or in a deeper plane at the intertransverse level. The same image that we have seen repeated infinitely in a paramedian sagittal plane shows the presence of two added barriers. In addition to the superior costotransverse ligament, the intertransverse ligament and radiated costotransverse ligament should impede the free diffusion of the drug into the paravertebral space. But in 2021 and later in 2022, Tae-Hyun and colleagues published the best and most realistic description of the paravertebral space and its anatomical limits. In their two articles, the author uses three-dimensional images from computerized microtomography. Unlike what we initially thought, where the internal intercostal membrane continues with the superior costotransverse ligament forming a membrane without a solution of continuity and impermeable to the passage of anesthetic, they demonstrate the presence of two openings, or slits, in the posterior or roof boundary of the paravertebral space. One lateral slit between the internal intercostal membrane and the costotransverse ligament, and another medial slit between the costotransverse ligament and the vertebral body or intervertebral disc. In the same paper, they describe the superior retrocostotransverse space. This space is located posterior to the superior costotransverse ligament and is filled with adipose tissue, muscle filaments, and connective tissue, what we previously knew as the intertransverse connective tissue complex. At the same time, it contains the dorsal ramus and part of the spinal nerve as it exits through the foramen. The medial slit is what we have traditionally known as Creuvelhia's costotransverse foramen, and it will also be the exit opening for vessels, dorsal vein and artery, and dorsal roots, into the paraspinal muscles and posterior vertebral arch. The lateral slit communicates directly with the ventral ramus, intercostal nerve. In 2022, using the same methodology, the same author comes back with a representation of the spread of the anesthetic, taking into account the structural changes of the paravertebral space and its limits described by himself a year ago. Using cadaveric paramedian sagittal cuts and microtomography, he emphasizes again the presence of the retro-superior costotransverse space and its importance in the diffusion of local anesthetic when injected inside it. They find a third access channel from this space to the paravertebral space, the costotransverse space medial to the radiated costotransverse ligament. This space is delimited by the extra-articular part of the rib and the transverse process, which we previously mentioned in the initial anatomical description. With all these new anatomical findings, we now have to decompose the paravertebral space again and its boundaries to understand the possible mechanism of action of paraspinal blocks. If we reconstruct these structures from scratch, from posterior to anterior, the internal intercostal muscle continues with the internal intercostal membrane, inserted into the upper and lower edge of contiguous ribs. The superior costotransverse ligament inserts between the tip of the transverse process and the immediate inferior rib. This ligament leaves a lateral slit between it and the internal intercostal membrane. The external intercostal muscle, which covers the muscle and internal intercostal membrane, also inserts between contiguous ribs. The radiated costotransverse ligament, costotransverse articular capsule, inserts into the lateral edge of the transverse process and rib, leaving a more caudal space that we call the costotransverse space. The intertransverse ligament is a thin ligament that inserts on the lateral edge of contiguous transverse processes. The lateral costotransverse ligament provides stability to the joint. The intertransverse muscle is a thin muscle that inserts like the ligament between contiguous transverse processes. The rotator longus and brevis, as well as elevators longus and brevis muscles, will be part of the retrocostotransverse space, like the multifidus, which is a less powerful muscle than in other anatomical areas. The medial opening is known as the Cruvelier costotransverse foramen, where it emerges to the surface by crossing the erector spinae plane. Reconstructing the cross-section in an axial plane with the new knowledge we have acquired. At the level of the costotransverse joint, we can identify the costotransverse space. Several millimeters below, where we do not find the rib and only the transverse process, we will identify the lateral slit between the superior costotransverse ligament and the internal intercostal membrane. At the level of the lower facet joint, we can identify the medial slit, which corresponds to the exit of dorsal branches and vessels towards the posterior, Cruvelier costotransverse foramen. In an ultrasound image, we can identify the posterior intercostal artery and the exit of the dorsal artery heading toward the erector muscle. Changing to a paramedian sagittal plane above the tip, distal end of the transverse processes, we will identify intertransverse ligaments, superior costotransverse ligaments, and costotransverse radiate ligaments. The retro-superior costotransverse space is found posterior to the superior costotransverse ligament. Moving slightly medial, the intertransverse ligament and costotransverse radiate ligament will no longer be identified, and we can observe the medial slit where the dorsal vessels and rami exit the paravertebral space and enter the retro-superior costotransverse space. This opening could be a point of access for anesthetics into the paravertebral space. In the ultrasound image, the dorsal artery is identified as directed toward the erector spinae muscles. With a more accurate description of all the paraspinal structures, we now have to simulate the possible path of the local anesthetic as it travels toward the paravertebral space. What I'm going to show you is a graphical translation with a touch of imagination of the theories described in previous articles. After bony contact with the transverse process and injection of 20 milliliters of the chosen solution, the local anesthetic spreads longitudinally below the erector spinae epimysium and over spinous processes and intertransverse ligaments in a first step. Since the intertransverse ligament is a filamentous ligament, part of the local anesthetic will passively spread into the retrosuperior costotransverse space in the second step. In a third step, a small amount may reach the paravertebral space by passing through the medial and lateral slits or the costotransverse space. This fascial spread that occurs in the first step could facilitate the multi-segmental diffusion of the local anesthetic, enabling it to reach a greater number of segments, albeit at the cost of a lighter block of the ventral ramus. On the other hand, in intertransverse blocks, the injection of the local anesthetic is not performed in a fascial diffusion plane. It is deposited directly into the retro-superior costotransverse space, bypassing the first step of the ESP block. Due to the volume and pressure of injection, the anesthetic will rapidly spread through the costotransverse spaces and medial and lateral slits, producing a more dense block. It is unclear whether being injected into a compartment and not on a fascial plane, like the ESP, could reduce its multi-segmental diffusion or whether it would occur through the paravertebral space itself. Further studies are needed to demonstrate this, according to the behavior of the local anesthetic. While in the paravertebral block, a complete blockade of the spinal nerve is obtained, and therefore of the ventral and dorsal rami and sympathetic chain. In the ESP block, the blockade of the dorsal rami would occur constantly, since this branch is found in the retro-superior costotransverse space. On the contrary, only a small amount of anesthetic would reach the ventral rami fibers, producing a differential blockade of this branch and the sympathetic chain. It is believed that the intertransverse blocks would act very similarly to the paravertebral block, producing a denser blockade of the dorsal adian-ventral rami as well as sympathetic, although more research is needed to demonstrate this. Thank you very much for bearing with this imaginative bombardment with an anatomical basis. I want to remind you that what I have shown you is a graphic translation of the studies we have, some imaginative touches, and in no case a contrasted study. Thank you very much.